Good afternoon, good morning, good evening, wherever you are in the world. It's a huge pleasure to be with you today and to welcome you on behalf of the Heart Failure Policy Network to the first Heart Failure Policy Summit session for 2022. I hope you were able to join us last year in the first ever Heart Failure Policy Summit, and welcome back again for those of you joining us in the second year, and welcome to those joining us for the first time. My name is Ed Harding. I'm the Network Director of the Heart Failure Policy Network, and it's a huge pleasure to be your chair today for session one. A quick introduction to us. We are the Heart Failure Policy Network. We're a multi-stakeholder platform working to develop policy recommendations and to raise awareness to improve care for heart failure. We bring together policymakers, patient advocates, healthcare professionals, and experts and decision makers from across many sectors to do this. Our mission is to challenge the historical picture of low investment and poor political understanding of heart failure. Our aim is to secure comprehensive, modern plans for heart failure in every country, delivering effective and person-centered care backed by meaningful investment. Our thanks to our sponsors today, without whom this work would not be possible. Our thanks to Boehringer Ingelheim, Roche Diagnostics, AstraZeneca, and CSL Vifor. An introduction as well here to the Heart Failure Policy Summit overall. This summit aims to be a catalyst and a service to the heart failure community in driving discussions, collaboration across many sectors to achieve the success that we want to see. Across the 4 summit sessions from today until November 16th, we seek to answer 4 questions that are critical to our community and to this important and shared mission. The questions are: how can we reach top-level decision makers and convince them of the value of investment in heart failure? What can we learn from each other, not only in optimizing healthcare systems, but in leading the case for change? How can we be stronger together as a community of all sectors? And what do you need from us at the Heart Failure Policy Network going forwards? It's our great honor at the Heart Failure Policy Network team to play our part in this shared endeavor. So today we will start with session 1 of the 2022 Heart Failure Policy Summit. Thank you for joining us. In particular here, we will be focusing on leading policy examples and in the art and science of engagement of decision makers. A quick bit of housekeeping before we start. If you have problems with the video, please refresh your page. If you prefer, you can turn on auto-generated subtitles by clicking on the option at your bottom right. We welcome your comment on social media, and you'll see us commenting and tweeting throughout the events and the summit as a whole. I hope you'll join us. Moving to our agenda, I'm delighted to say that we have a fantastic lineup of speakers with you today and in our many other sessions coming up in the weeks to come. This includes national and European level decision makers, as well as heart failure advocates and clinical leaders that have driven real change in Spain, Canada, France, and Germany. The session will end with a roundtable discussion on how to achieve collaboration in heart failure and how we could maximize more impact at the national and European level. Please feel free to post your questions in the Q&A box. We will answer them during the session if we can, or in the community chat on the event platform after the session. So please remember, we'll note all questions and we'll take them forwards, even if we can't answer them in the session today. So let's begin session 1. We are particularly honoured today to start this summit with a keynote address to the heart failure community by Micheál Martin Taoiseach of Ireland.
Gemani díomh tránóna, bhí luchair orm an cura chun láirtliv ar fadanmh achlacha. Tá fáilte mhór roimh chuig an ócáid, cuinse áthas orm a bheith ann túsachar leis na himachtaí. I consider it an honour to be associated with this conference, as the work you are doing across your varied disciplines is literally saving lives. The topics you are covering in your sessions, innovation, health inequalities and person-centred care, are very close to my own heart and align closely with the reforms underway in our Irish health system. The work that you as a network do is critically important, not just in terms of your work helping to drive meaningful changes in policy and practice, but crucially your efforts to raise awareness surrounding heart failure. The statistics on cardiovascular disease are indeed sobering. As a non-communicable disease, cardiovascular disease, which includes heart failure, remains a major killer and cause of chronic illness in Europe and the world. Cardiovascular disease is the single most common cause of death globally, accounting for nearly a half, that's about 17.9 million people, of annual non-communicable disease deaths. Recent studies have shown that 1 in 5 people over the age of 40 will develop heart failure in their lifetime, and at least 15 million adults in Europe live with the condition. Heart failure is a significant demand on our health services, is responsible for a reduction in quality of life and life expectancy, and is generally accepted to have a morbidity impact similar to cancer patients. Here in Ireland, cardiovascular disease causes 28% of deaths and was the second biggest cause of death in 2019. Yet this need not be the case, as most deaths from cardiovascular disease are considered preventable. And that's why heart failure prevention is paramount, and why in Ireland detection and prevention is a priority. Sláinte to Care, our national programme to transform health and social care services in Ireland, is driving new investments in cardiovascular disease prevention and management for people who have suffered a heart attack, stroke, atrial fibrillation, or who are living with heart failure. We currently have a national clinical programme for heart failure, demonstrating our commitment to improve quality of life for people living with the syndrome. There has been significant investment in integrated care programmes for chronic disease, and this investment will, we hope, significantly improve all aspects of heart failure care, including speed of diagnosis, access to cardiac diagnostic and therapies. In 2020, we began a structured programme of chronic disease prevention and management in primary care, targeting those at the greatest risk, for example, those with heart failure. The objective of the integrated care programme is to design an integrated model of care that treats patients at the lowest level of complexity that is safe, timely, efficient, and as close to home as possible. The programme includes prevention, targeted case finding, and ongoing management, helping us to catch cardiovascular disease risk factors early, manage them effectively, and slow or halt disease progression. Focus is also placed on e-health platforms in heart failure. We are promoting pioneering innovations like the Heart Care at Home, a primary care project, which is open to all people with heart failure in Ireland. To get heart failure specialist care to a wider cohort of patients, we are rolling out virtual consultation on a national basis, which allows online, real-time discussion of heart failure case questions with the family doctor. While I mentioned earlier that the numbers are sobering, it's also important to say that there has been notable progress in both therapeutics and structures of care, improving quality of life and life expectancy. Internationally, there continues to be remarkable development in therapeutics for management of heart failure, and the evolution of these therapies, including novel proven therapies, has improved life expectancy dramatically. In addition, increasing focus on self and home management observation with remote invasive and non-invasive devices allows closer monitoring of the higher risk heart failure patient. These advances demonstrate the importance of innovative collaboration with device development companies. Ireland has a strong track record in leading Europe and the world with policies to tackle cardiovascular diseases. For example, as Health Minister, I brought in the first tobacco legislation in 2002, and I led the first national ban on smoking in the workplace in 2004. We also led the drive to introduce plain cigarette packaging in Europe. Under the Irish presidency of the European Union in 2012, the Tobacco Products Directive was given highest priority under the facilitating agreement among the member states. Our wider community of clinical practice in heart failure has provided leading research and innovation that can continue to inspire the world. For example, the Stop HF project is a dedicated heart failure prevention strategy where risk for heart failure is personalised and those at higher risk receive shared care, that is, with a general practitioner and heart failure specialist to modify the risk. This first-of-type concept has been proven to be successful and has resulted in changes in international guidelines, most notably those of the American Heart Association, American College of Cardiology. In short, we are among the world leaders now in developing strategies to prevent heart failure. And our approach has worked. We have realised a drop in hospital admissions for heart attack and a reduction in stroke mortality in Ireland. However, we also recognise that we still have a long way to go if we are to prevent unnecessary hospitalisations and deaths and maximise people's quality of life. More focus is required on the prevention of heart failure. There is evidence to suggest that while we are making progress, we are not reaching a significant proportion of the heart failure population. Recognising we can do more, we have commissioned a national review of our adult cardiac services, which includes heart failure. Patient outcomes, patient safety, and ensuring public confidence in cardiac services are central to the national review. As a government, we support the vision of a high-quality, safe, accessible and sustainable cardiology service. We recognise that capital investment also has a key role to play, both in enhancing cardiac service provision and as a driver of reform, and this is reflected in our National Development Plan out to 2030. Now let me turn to you, the community of clinicians, patient advocates, healthcare managers and decision makers who are leading in your fields on this issue. In opening this Heart Failure Policy Summit, I extend my support to all people living with heart failure and to the carers, professionals, campaigners, innovators and policymakers who are leading change. In Ireland and across Europe, the advances we have seen in heart failure would not be possible without your dedication, activism and vision over many years. I offer my thanks and encouragement to you all. I welcome the new President of the European Society of Cardiology's Heart Failure Association, Professor Giuseppe Rosano, and I thank you for his support. I thank him for his support during this summit. Tá súlagam go nairóig go mailibh leis an ghnú molig seo, ina méid sibh fad ag fálam agus ag fáil spreaga óna chéile, agus táim ag súil le béim a legan clise crí I deanta a chéile amach an seo. Thank you very much indeed. Take care.
Huge thanks and appreciation there to Taoiseach Micheál Martin for his kind address to the Heart Failure Policy Summit. This first ever dedicated address on heart failure by a serving European Prime Minister marks a historic occasion for 15 million people across Europe. A watershed, we argue, in the progressive defeat of political misunderstanding of this common and manageable and preventable syndrome. The Taoiseach's personal involvement sends a message to the whole world that governments must express their strategic vision in heart failure, starting at the highest level. Now, it's a huge pleasure to turn to our fantastic list of speakers across the rest of the day. In particular, since the pandemic, mindsets have shifted considerably towards the need for greater international collaboration in research, innovation, and system alignment, including across Europe. However, CVD initiatives, including heart failure, need to be represented more strongly in the future, making it very important that the heart failure community understand the opportunities and the national benefits that this might bring. With that in mind, it's a great pleasure to hear from Ms. Veronique Vospaal, Principal Advisor for NCDs at the European Commission, who will present some of the European Union's flagship programs, including the Healthier Together initiative, which includes cardiovascular diseases as one of its key strands of focus.
Thank you, Adam. So dear participants, it's my great pleasure to address you on the occasion of this summit dedicated to heart failure. Indeed, each year there are more than 6 million new cases of cardiovascular disease and over 1.8 million cardiovascular disease-related deaths in the EU. For the EU economy, that accounts for over 210 billion euro a year. Already before the pandemic, cardiovascular diseases were the leading cause of death globally and the #1 cause of death in the EU. Across Europe, differences in cardiovascular disease prevalence and death are well documented, and notably higher death rates in Central and Eastern European countries compared to Western countries. Gender inequalities are also observed, with women on average more affected from cardiovascular diseases than men, and with gender gaps being more evident in Eastern European countries. Hypertension and cardiovascular diseases are the most prevalent pre-existing conditions, and people with comorbidity appears to be at the highest risks of death from COVID-19. Unhealthy diets, physical inactivity, smoking, and harmful use of alcohol are the key causes of non-communicable diseases, including heart health. They are responsible for the overwhelming majority of Europe's disease burden. In order to address this major challenge, the Commission supports EU member states to reach the targets of the World Health Organization on the Sustainable Development Goals and to reduce premature mortality on non-communicable diseases. In the context of cardiovascular diseases, we support member states in transferring best practices on health promotion and disease prevention, including on physical activity, nutrition, and other risk factors such as tobacco consumption. European Physical Activity on Prescription is a project transferring a Swedish best practice to 10 other member states. The Young 50 project exports the prevention and screening model for cardiovascular diseases developed in Italy to Lithuania, Romania, Luxembourg, and Spain. Under the EU for Health Work Plan for 2021, the Commission allocated 7 million euros for the transfer and implementation of validated best practices by means of 2 joint actions with EU countries, one tackling diabetes type 2 and the other promoting healthy lifestyles and obesity prevention in vulnerable groups. Further actions have been included under the Commission's new Healthier Together initiative that contributes to efforts of the EU countries in reducing the burden of non-communicable diseases. The European Commission presented the objectives of the Healthier Together EU Non-Communicable Diseases Initiative in June. The key aim is to support EU countries in identifying and implementing effective policies and actions to reduce the burden of major non-communicable diseases and improve citizens' health and well-being. The initiative covers the 22-27 period and includes the following 5 strands: health determinants, cardiovascular diseases, diabetes, chronic respiratory diseases, mental health, and neurological disorders. While these strands enable addressing challenges of each disease group, the initiative as such promotes a holistic and coordinated approach to prevention and care, as well as the reduction of health inequalities. It also supports better knowledge and data, screening and early detection, diagnosis and treatment management, and the improvement of quality of life for patients. The 2022 work program of the Healthier Together initiative supports implementation of actions with dedicated funding of 55 million euros for work with EU countries, starting with cardiovascular diseases and diabetes. A call for proposal for stakeholders is open until the 21st of February 2023 on cardiovascular diseases and diabetes. Another joint action for the member states will focus on health determinants and a call for stakeholders is also open with the same deadline. You can find details on those calls on the site of the executive agency dealing with the EU for Health program, HADEA. So your event is very timely and relevant for the EU policy. I can more than welcome your efforts and contribution. Thus, I wish all the best with your summit. Thank you for your attention.
Thank you very much, Ms. Vospar, for the extremely helpful brief to the heart failure community on the vital work that the Commission is doing. As you just heard, there are many programs the heart failure community can take active interest in. We pledge that we at the Heart Failure Policy Network will do our best to make sure that news of this is communicated very actively. And in case you missed it, a call opened 21st of February 23 with 55 million euros in funding available around cardiovascular and diabetes research, with an open call for proposals. So the colleagues involved in clinical research, something to be highly aware of. Looking forward to speaking with you in just a minute. It's my huge pleasure to move to three colleagues who have been very active at the national and in some cases international level in leading various new initiatives that advance cardiovascular disease or heart failure. In particular, many of you may have heard of the new Spanish National Cardiovascular Strategy. It certainly caused huge interest across the world of cardiovascular disease. It's even more interesting to us because it has a dedicated and sophisticated section on heart failure. So without any further ado, we're thrilled to be here with the lead coordinator, Professor Hector Bueno, researcher at the Spanish National Center for Cardiovascular Research and a clinical cardiologist. Professor Bueno, over to you.
Thank you very much. It's my honor to share with you the probably the most ambitious initiative ever done in Spain to improve cardiovascular health in our population. So this is the work of more than 100 people, including health specialists, cardiovascular specialists, health professionals, but also non-health professionals, decision makers, patients, and other. Spain has a national health system, but actually the delivery of healthcare is decentralized, is given in 17 autonomous communities, regions. So it is essential to have cohesion and equity across regions, something which could be an analogy with what happens in Spain. So we have the strategies as a tool for that. The strategies are developed by the Ministry of Health, usually in these multidisciplinary teams, and they have to be approved by the regions as to have a local implementation with local priorities, calendars, and so on. So the National Strategy on Cardiovascular Health was released a few months ago with the aim to improve the level of cardiovascular health of the Spanish population, reduce the incidence and prevalence of cardiovascular disease, adopting interventions with proven efficacy, effective, safe, and sustainable. This is the framework that we used. We started from the healthy individuals, and we know that there's a number of individual factors, genes, exposures, lifestyles, but also social, economical, and political factors that influence health and the development of disease, which is initially usually in cardiovascular diseases asymptomatic, and then ends up with acute developments of events or chronic diseases leading to terminal ill patients and death. So it is essential in a way to improve cardiovascular health, take into considerations all these factors, which are definitely not only in the cardiovascular area and not only in the healthcare system. So the shift has been moving from cardiovascular disease to cardiovascular health, from the healthcare system to this society, from patients to patients and citizens, and from healthcare professionals to all players involved. This is essential really to improve care. The design of strategy has six transversal lines: health promotion, prevention and early disease detection, citizen empowerment and participation, knowledge management, research development and innovation, equity, comprehensive care of persons with acute and with chronic cardiovascular disease. These are crossed with 7 longitudinal lines in which 3 specific axes, which are continuity of care, patient safety, and information on cardiovascular health status as a leverage for improvement. 4 specific syndromes were chosen given their impact in the society, which are ischemic heart disease, heart failure, arrhythmias, and sudden death, and heart valve disease. So this creates kind of matrix taken all together, and you can see here this marked the heart failure. And we asked the experts to identify what were the critical points in Spain that needed a specific attention for the strategy, and so we did. So the strategy is designed with these specific critical points, 27 in particular, which are depending on the lines of action that we mentioned. There's 99 strategic objectives, 134 actions, and 61 indicators for the follow-up. The specific critical points for heart failure were improvement of early diagnosis and detection of heart failure, organization of heart failure care through integrated multidisciplinary units or programs, or organization of the care for cardiogenic shock through regional referral networks. These were identified as the main needs in Spain now. Each strategic, each critical point has a strategic aim, as you can see for the critical point 1, to foster the early diagnosis of heart failure in any healthcare setting. And one of the action, the critical points action, is to have availability of natriuretic peptides measurements in any healthcare setting. That means primary care. There's quality indicators defined. There's formulas on it. I just showing you what is it. I'm gonna go through that. Fostering the implementation of multidisciplinary organization of heart failure care models, including all actors across all levels of care, is the second line, with the specific actions in terms of creating these teams and establishing homogeneous and common criteria across the nation. And as mentioned, regional networks for the cardiogenic shock to identify those patients who may benefit from advanced care and how they can be transferred in a safe manner with their specific actions. We decided a strategic map, which is designed from top to down, from the objectives in the cardiovascular health, the needs from citizens or patients in the healthcare system, the processes and the structure and knowledge. But as you know, the implementation actually is analyzed from down to top. With this, we developed these scorecards, which analyze the strategic basis and the lines of action. And this is a look of what the strategic map of the whole national strategy looks like. I'm not gonna go through it. It's just an example. In each line of action, and this is the one for heart failure, is looks like, fill in the specific boxes for the lines of action, the strategic aims. This is a really ambitious plan. We're really would like to share our experience with the rest of Europe, and we believe that it may be of help for other countries of whole Europe. So thank you for your attention.
Thank you so much, Professor Bueno, for walking us through that. I'm sure we could spend a lot longer going through the strategy, but I do believe it's vital that we all see this and that colleagues across Europe can take inspiration from this. And as you say, the dedicated focus there on heart failure and the commitment to data and review. Looking forward to the discussion later with you. Moving on to another example at the national level and increasingly international, very excited to be here with Dr. Gillian Code from HeartLife Canada. Gillian is co-founder and president of HeartLife Canada, and she is with us today to discuss the HF Patient Charter and its journey to global expansion. Over to you, Gillian. Thank you so much for being with us.
Thank you so much, Ed. It is a distinct honor for us to be here, and we appreciate the platform and the support and the inspiration that the Heart Failure Policy Network has certainly given us as a patient organization. If I could start my slides, that would be wonderful. Thank you so much. I do have a few slides, so I'm gonna run through them, but and I will get to the meat of them in a second, but I do want to highlight that none of this can be done without partnership, without understanding, and without a community around us. And HeartLife really was founded not only by myself, but by a fellow patient, Mark Baines, fellow patient and transplant recipient, Mark Baines. And I myself have had 2 heart transplants. And so it's, as you will see, we've been really working quite hard to make a difference to Canadians. Next slide, please. But before I begin, I would first like to acknowledge on the lands in which I am joining you today. I would gratefully acknowledge that I live, work, and work on the traditional, ancestral, and the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. And I am actually living on the Lekwungen traditional territory known today as the Esquimalt and Songhees Nations, which is Victoria, British Columbia. Next slide, please. At HeartLife, our mission is really to, as a patient-driven charity, is to transform the quality of life for people living with heart failure. And we do this in a number of ways, but at the central core of our mission is by engaging, educating, and empowering our community locally, nationally, and hopefully globally to help create lasting solutions and build healthier lives, which is, I think, what we're all aiming for. Next slide, please. So the heart failure patient journey is really one that is fraught with ups and downs, and it's not a straight line. And one thing that became very, very clear to us is that we needed to capture on our own terms, from the patient and family care perspective, what it meant and what the journey looked like from a patient perspective. And this was important because we needed to build everything upon the patient journey so that we knew that we were honoring the patient journey. And as I mentioned briefly in the opening, I was diagnosed with heart failure at the age of 27 in 2005. And I know what you're all thinking. I can't possibly be as old as I look. Or did I say that incorrectly? Anyway, that was 17 years ago. And I wouldn't be where I am today without the incredible support of my family, my husband, and the patient community, but also through the hard work and dedication of my doctors and my nurses and my healthcare team. Next slide, please. But I'm also not alone in this journey. And so what we decided to do is over the course of, since our founding in 2016, we have spent a lot of time talking to our constituents, to our people, our membership, and learning from them that there are a lot of similarities in the experience of having heart failure But we wanted to further understand and take a data-driven approach to decisions that we make. So both from a qualitative and a quantitative perspective, and bringing together this mixed methodology to result in something that is robust and built upon the real life lived experience. And so as you can see here, I outline a little bit of the approach. The next slide, please. The heart failure or the Heart Life patient journey map is available on our website, and I do encourage you to have a look at it, and you can see in more detail the kinds of information that we captured. But in essence, what we did is with patients, the vast majority of the challenge, well, I don't want to say the vast majority, but a good deal of the challenge is the life before diagnosis. And this life is not adequately captured in many of the patient journey maps that are done by healthcare practitioners. And so this is why it was extremely important for us to capture this, because we instinctively knew this and understood that. And so there's really 3 phases to our journey map: the life before diagnosis, the diagnosis, and living with heart failure. Next slide, please. And through the research that we did, we came up with these really 7 overarching opportunities. And these opportunities we then took to transition and to transform into what is now our Heart Life patient and caregiver charter. Next slide, please. Thank you. And you can download the Canadian heart failure patient and caregiver charter, as well as the journey, on our website. But here's a quick link to it: heartlife.ca/charter. And the overall aim is to really bring us to the next level and aim for a national standard of care for Canadians living with heart failure and their caregivers. And because Canada is a vast country, as I'm sure you are all well aware, but we're only a country of roughly 38 million people. And in this country, and that's spread amongst a very, very large area. And so the experience of care is different from region to region, and even within our own province of British Columbia, for example, it's different from one city to the next, from the urban to the rural and remote community. Next slide, please. So what is a charter, and who is it intended for? Well, the patient and caregiver charter is really set out as a set of rights, but also a set of responsibilities to really support the creation and implementation of a national standard of care for Canadians living with heart failure and their caregivers. It helps us really outline what drives it is access to care, medical therapies, support services. And as I said, they vary widely from region to region. And who is it for? It's intended for patients, for caregivers, including family members and loved ones, healthcare providers, policymakers, and private payers. So it's meant to bring us all together, and so that we can have a conversation around the what it's like to live with heart failure, but it also what things people can take action on. Next slide, please. So why does Canada need a patient caregiver charter for heart failure? Well, the burden of heart failure, and I don't like using that word burden, but the burden of heart failure is profound on patients, caregivers, and our society as a whole. And we illustrate here stats from 2000 to 2012, 2013. And we do actually have some additional data to update this. But as you can see, there's been, at least in that small 10-year period, there was an increase of 43% of people living with heart failure. And we now estimate that there's close to 1 million people in Canada living with heart failure. And that's a really, really significant number of individuals, considering we only have roughly 38 million people. Next slide, please. And the burden on our healthcare system is really, really substantial. The amount of care that individuals require is just increasing, and it's estimated at this time that it costs Canada roughly $2.8 billion per year. Next slide, please. So what is the Patient Charter of Rights? Boiled down at its essence, it's really meant as the receipt of an accurate and timely diagnosis of heart failure. The availability of service and resources to support mental health throughout the care continuum. This is one that is really often left out because living with heart failure on that third aspect of the spectrum, it is important to manage our physiological health, but it's equally as important to manage our mental health, because research has been shown that one affects the other, and it's a vicious cycle. Access to educational tools, resources, everything we need to become fully empowered individuals in our own healthcare. Empathy and compassion from healthcare providers, access to a multidisciplinary care team, that includes everybody from a dietitian, the specialist physician, the nurse, the pharmacist, mental health support, cardiac rehab specialists, and your primary care team. The timely access to the best standards of care and medical therapies, and the opportunity to provide input into decisions regarding the future of research in heart failure. Many of our members have demonstrated that they want to be actively engaged in research because there is no cure for heart failure. So people want to be actively engaged and empowered. Next slide, please. And so we have this charter, and we are working nationally, locally and nationally to elevate it. But what we have also done is we've partnered with the Global Heart Hub, and you will be hearing from Neil Johnson, the executive director, later in the session. But the charter has really taken on a life of its own, and it through the Global Heart Hub. It was translated into an international version, and is now in more than 17 different languages, and in more than 30 patient groups across the world have endorsed it. And so it's really beyond the comprehension for me and for us at HeartLife to see how this has really taken things to the next level. Next slide, please. So where do we go from here? So what we are finishing up now is what we're calling the HF PACE. It's our Heart Failure Policy and Systems Evaluation. And so in partnership with the Institute of Health Economics in Alberta, we are working to develop a summary policy document that can be used, that is aligned with the charter, which is also aligned with our patient journey, to recommend data-driven approach, but also policy levers that can be used to translate the themes that we identified in our work into concrete action, so into policy change, and how we can measure and achieve that, and actualize that change. Next slide, please, and that's coming out shortly. Before I finish, I just want to say that the only way that we've been able to, one of the only ways that we've been able to do the work that we've been able to do is with the support and backing, the complete and unwavering support and backing of our clinician community and our nursing community. When Mark and I came together to form the HeartLife Foundation, we did so with one of Canada's leading heart failure and transplant specialists, Dr. Sean Barani. And between the three of us, we worked very, very hard but we also worked with organizations like the Canadian Cardiovascular Society, Canadian Heart Failure Society, and Heart and Stroke Foundation, and a number of other organizations across Canada. And we wouldn't be able to do the work that we do or stretch as far as we do without that collaboration, because what they've done is that they've empowered Mark and I to really be elevated as equals, and because they've seen us as equals from the beginning. And so rather than be patients of our disease, we are now, as you can see, becoming agents of change. And that part is really what it's all about for us. And that's why we say, you know, heart failure is not about failure, it's about life. And that's at the essence of what we do. So thank you so much. And I'll hand it back to you, Ed.
Thank you so much, Gillian, for that fascinating example. A huge congratulations on, I think, the incredible amount of work that has gone into that over many years, and on the successful and deep partnerships that you've been able to build. And I think the quite unique angle of building in the patient perspective and patient pathway together with also a clear care pathway as well, and with the data and metrics as well to back that up. I can quite understand why colleagues in many countries are very keen to follow your lead. So thank you for this service to the community, and congratulations again. I'm looking forward to your comments in the chat in just a minute.
Thank you, Ed.
Moving on to, oh, my pleasure. To mention as well, we had hoped today to hear from Professor Thibault Demy in France from the University of Henri Mordor. Regrettably, due to clinical pressures, he's unable to join us. And may I take this moment to give our appropriate thanks and acknowledgement to clinical colleagues and the pressures that they face, including those who are joining us today, possibly in the midst of a very busy clinical schedule. So thanks and appreciation for that. Moving on now to our colleague Winfried, Mr. Winfried Klausnitzer, who is chair of the Herzfrache Deutschland, and we're thrilled that he's with us today to present his Heart Failure Roundtable initiative in Germany, where he's brought together local policymakers, clinicians, health insurers, and patient representatives to develop actions and drive progress in heart failure care. Over to you.
First of all, Ed, many thanks for your invitation and the opportunity to present our project. At the succession and with support of the World Heart Federation, the association Herzschwäche Deutschland, means Heart Failure Germany, organized a roundtable on the subject of heart failure on March 16th this year in Nuremberg, Germany. That was the second roundtable on heart failure worldwide. The first was organized from our friends from Heart Life Canada. Thanks for your mental support. In Nuremberg, we had approximately 30 participants were present, and 50 participants were connected online. We are proud to have brought together at one table patient and their relatives, patient organization, cardiologists, nursing experts, politicians, health insurance companies, professional association, the pharmaceutical industry, and press representations. It was not really difficult to get the right and important and necessary guests on board. Most of the time, it was like running into an open door. Sometimes we had to explain what a heart failure is, but it was pretty easy to get the right persons in our partnership. The event was opened by Professor Dr. Stefan Balders, President of the German Society of Cardiology, and Professor Dr. Bauschinger, Chief of Physician Cardiology, Nuremberg Clinics. After the presentation of the roadmap heart failure of the World Heart Federation with Dr. Sarah Kraus, the current situation of heart failure care was described in 5 presentations, and weaknesses and necessary improvements were identified. First was Dr. Klaus Edel, a medical director of the Cardiovascular Center in Hersfeld-Rotenburg, with a theme prevention and rehabilitation on heart failure. The second was Professor Roger Jacke, Director Country Policy of Vivo Pharma, with the theme, what opportunities does the new German coalition agreement offer? Then it was my part with experiences and need of patients. The fourth was Professor Matthias Bauschinger, heart failure as deadly disease. And the last one was Astrid Hüsken, nursing scientist and first chair of the German Federal Association for Heart Failure Nurses, with the heart failure, the view of nursing. After a subsequent round of discussion, everyone involved agreed that the improvement can only be achieved if everyone involved in the care of these patients regularly meets, exchanges ideas and searches for and find solutions together. The important wishes and demands were better networking among the individual groups, eliminate disputes about overcompetence, acceleration of the introduction of the disease management program heart failure in Germany, introduction of anti-pro-PNP in preventive medical checkups in Germany, more public relations and political commitments is needed. The important decision were a joint day of action to be organized for 2023 in order to get as much attention as possible from the media and the public. The second follow-up meeting take place in 2023. Now our planned day is 29th of March with the planned topics: quality of life for heart failure, awareness and report on joint actions, planning and further joint action. And that's a short report from our event. I thank you so much for your attention. And thank you, Ed.
Thank you, Winfried, for joining us. Your presentation and initiative reminds us all that progress can be held back by many factors, and that it's so important to gather different stakeholders together, and as you have described, face into some of the very basic questions around competencies, the vision of care that all sides wish to see as a critical first step in advancing a consensus, and how powerful that consensus can then be in terms of challenging what can seem like immovable barriers and things that hold you back. So thank you very much for joining us in that, and looking forward to your comments again also in a second. So that concludes our the presentations, and I'm excited to move forward into our roundtable discussion. Our first 3 respondents will be Professor Giuseppe Rosano of the European Society of Cardiology Heart Failure Association, Neil Johnson of the Global Heart Hub, and Mr. Billy Kelleher, MEP. So let's get going. Professor Rosano, you're joining us today, and congratulations on your recent appointment or beginning of your term as the ESCHFA president. We've heard the Irish Prime Minister acknowledge much progress in CVD, but also call for more effort in addressing heart failure and in preventing heart failure. What relevance does this have in other countries across Europe?
Thank you, Ed. And the Prime Minister's word are very relevant, not just for Ireland, but across Europe and worldwide, because we have guidelines, but we need to make sure that they are implemented, but also that the healthcare can deliver on them. because we can see in several European countries, for example, that despite the strong evidence and recommendations, many medicines, many interventions, many devices, and also diagnostic tools are not covered by the national healthcare system. And these are as a consequence for patients who are living with heart failure. Now, the consequence of a poor political awareness are very real for many millions of patients living with heart failure. As that if we don't have enough political awareness, then there will be underinvestment in all the care pathways, and that leads to an undertreatment, underdiagnosis of patients with heart failure. And I wish to congratulate the actions that the Irish Prime Minister took in Ireland, but we need other heads of state to follow his lead and to convert into a real commitment for heart failure in forms of national plans with proper investments, but also we need to create a critical mass that can act at European level in order to recognize heart failure as a priority.
Thank you, Professor Rana. I think excitingly, we heard the Taoiseach acknowledge the need for capital investment, in particular this renewed focus on prevention. And what's the clinical significance of this?
And this is very timely and also highlights the deep knowledge of the Irish Prime Minister on heart failure, because the 2021 heart failure guidelines give a very important focus on prevention of heart failure, especially in the high-risk group. We now have a huge opportunity for action, and this effect and this action is very cost-effective. Now, my colleagues across the Heart Failure Association will be delighted to support this initiative of the Irish government throughout Europe and worldwide in escalating the response and indeed the response of any other government. What is important, however, is besides prevention, we must also focus on the treatment and for patients with heart failure, since, as I said earlier, the diagnostic tools and treatments must be made available to all patients across Europe and without any distinctions. Otherwise, we will have Europe going at 3-4 different speeds. And this is something we have already seen with the publication of the HFA Atlas, but also with all the statistics published by the Heart Failure Policy Network, where we see a big disparity in treatments and in survival of patients with heart failure across Europe.
Thank you, Professor Rosano. We've heard some fascinating examples of patient advocates and clinicians working together. Speaking as a leading representative of the heart failure clinical community, what would your words be? How can clinical leaders work more closely with others to build policy and political momentum?
I think that we all need to work together, and we need to build a critical mass that will work and through advocacy, because we'll need to make sure that all the politicians will understand the importance of heart failure, on the burden of heart failure on society, on patients, and also the economic burden of not treating heart failure appropriately. So I think we have to learn from cancer, where from the beginning, the NGOs, patients, and clinical leaders, they clustered together in order to make changes in policies. And this is what we need to do. I mean, we need to get together. The Heart Failure Association can coordinate all the clinicians across Europe, but we need associations and organizations like the Heart Failure Policy Network. We need patient groups in order to make our voice heard. And for example, we've launched the quality of care centers across Europe. This will be a project coordinated by the Heart Failure Association. This is a very important project because we'll highlight in the different countries where the centers that will provide excellence in care in heart failure will lie. But this will be useless without any effect on patients and without any effect on advocacy and without any implementation of guidelines into clinical practice that can be made available through policy actions. Because if you go, for example, in Italy or in Spain or in Greece, you find that some of the key treatments for heart failure, are difficult or impossible to be prescribed, even by cardiologists working in cardiology clinics. So this is something where we all need to work together.
Thank you, and you can certainly count on the support of the Heart Failure Network in facilitating that. And lastly, Professor Rosano, you've just started your 2-year term. What do you want to see? What does the HFA want to see in terms of policy over that period?
As I said, this is something that we'll need to build over time, and it's not something that we can build in 1 or 2 years. I would like to see a stronger partnership across the policy and advocacy world, as I said, with HFA doing its own part, with the Heart Failure Policy Network doing its own part, but also having patient groups that work together. And I'm delighted to announce that I've accepted to join the Heart Failure Policy Network Steering Committee. And we've started also a path together with the HFA, and we'll see how this might work better across the many working groups and associations at the national level. And I would like to strongly suggest to my colleagues attending the summit to spread the news and the importance of working together, working with patient groups, working with associations in order to make the voice of patients with heart failure heard at the European level.
Thank you very much. What an exciting proposition, and I think an exciting time. Neil, turning to you, I'm sure you share the sense of excitement. I think that we all feel on this call. Thinking of this bigger perspective, you were kindly one of the HFPN's founding members all the way back in 2015. You've seen much of this journey. Since then, a lot has changed. The patient community has grown a great deal, including the Global Heart Hub and the HF Patient Council. How far have we come? I think you're on mute, Neil. Sorry.
Firstly, thank you for the opportunity to be part of this great and important meeting, and fantastic to see such a strong Irish presence here with our Prime Minister Taoiseach and one of our members of Parliament. You're right, I've been part of the Heart Failure Policy Network for a number of years, and I think, to coin an Irish political tagline, there's a lot done and a lot more to do. And it was very encouraging to hear our Taoiseach talk about the importance of prevention. Really pleased to hear Professor Rosano speak so positively about the need to collaborate and engage, and rightly pointing out that in the area of cancer, for example, the patient community has made a huge contribution to driving things forward in collaboration with the clinicians and other stakeholders. So I think that heart failure has had a bad press, and it's had a bad press because it's complex, it's chronic, it's traditionally in the older population. There's been a lack of therapeutic innovation, and within cardiology itself, it's probably not the sexy end of the profession. It's not where all the cardiologists are rushing to work. But what has changed over the last number of years is that I think it's due to efforts like your organization, the Heart Failure Policy Network, due to the innovation in medical and device technology, due to strong advocates in the clinical community, the likes of Professor Rosano and others. I think that, and I think also the increasing contribution of the patient voice, there is now, I believe, a realization of the scale and burden of cardiovascular disease on the healthcare system, which we knew was there, but perhaps is now under spotlight. And it's a big burden, the most common cause of admission to hospitals over 65 across Europe. There are neurotherapeutic and medical devices, and there's a huge realization of the impact heart failure has on the individual. You've heard from Winfried, you've heard from Gillian. So it has a huge burden on society, on the individual. And so we have a lot to do. We know the answers, and we know how to do it. But ultimately, as has been said, this is going to require policy change driven from the top. We need our political leaders to understand the situation on the ground, and we need collaboration between the patient community, the clinicians, and all stakeholders, and it can be done.
Thank you, Neil. I think we all recognise that many of our colleagues in this community have spent many years doing what they think is right, possibly in the absence of the recognition that they deserve. That's something that I personally and also the rest of my team are 100% committed to ensuring that this is brought fully into the public limelight as is rightly deserved. With that in mind, getting a serving Prime Minister to talk about heart failure when we first sat down all those years ago would have seemed a tall order, but we've done it today. So how can we build on the Taoiseach's address and get other Prime Ministers to follow his lead? Who do we want to come in 2023?
Well, our Taoiseach is no stranger to leading on health. As he mentioned himself, he was one of the first to drive the ban on smoking, which has a huge impact on cardiovascular health. To me, what I particularly picked up from his presentation was the focus on prevention of heart failure. And I think he was making reference to, even though he didn't call him out, the great work that's being done in Ireland, for example, by Professor Ken MacDonald in the Stop HF project. But to me, the bigger issue here, if I can, is the societal complacency that we can see and see the reality of in accepting the level of ASCVD, atherosclerotic cardiovascular disease, across the world. We're just not taking it seriously. And everybody is automatically rushing to highlight our successes in the field of intervention and treatment, but far too little attention has been put on prevention. We need to aggressively tackle this head on with national plans like we're seeing in Spain. And the Spanish plan has been applauded, and so it should be. It's fantastic, it's very comprehensive. But in another way, we should be standing back from this and saying, it's almost the obvious. And why is it not the case that every European country has a national cardiovascular plan? And within that plan, it has a strategy that calls out its prevention strategy. And within that plan, it has a very clear call to action on heart failure, because it is one of the areas of cardiovascular diseases presenting a huge burden. So for me, the challenge now is to build on what we've seen today, most senior government leader who is speaking out on the need for prevention, who's calling out the necessity to impact on heart failure. So I think there's an opportunity for us, and maybe again, it's potentially from the ground up, from the patient community, to try and pull together a joint delegation, perhaps, of all stakeholders who could now, knock on the doors of other European leaders to try and get to a point where this issue really becomes a political priority.
Thank you, Neil. Absolutely. We've certainly got the data to justify that, and we'd have plenty to say if we got 10 minutes in front of every Prime Minister or head of state in Europe. I'm sure between us and our community, we could get them to understand the key issues. Thank you. Neil, one last question for you. So we've heard from many sectors at the summit today. I'm sure quite a few colleagues from, say, clinical leadership or health system management are thinking, how can I best work with patient advocates to advance barriers, tackle misunderstanding? What would your message to them be?
I think it's very clear that we do need to work together. And as I reiterate the welcome to Professor Rosano's call for this as well, to his colleagues leading the clinical community across Europe, there's an opportunity to engage. It's the whole purpose of the Global Heart Hub, actually, is to bring together the patient community to try and create that voice and to build the capacity and capability of that community to work with stakeholders. I think the example that you've seen from Gillian in Canada is an exemplar of what can be done. And it's a bottom up. You have two patients who have gone to the extreme of heart failure to transplantation, taking the initiative to learn from their experience and create the patient journey, which ultimately has developed to the patient charter. And we in the Global Hub are delighted to have taken that charter and with endorsement from Gillian's organization to internationalize that. And it's a good example of what the patient perspective can bring to this discussion. But we need much stronger commitment and support for the development and engagement of the patient voice. And by that, I mean structures by which this can happen. So for example, in Lithuania, in the Czech Republic, in Poland, I'm aware of actual formal structures by which the patient community can engage with government. And these are some things that again, should be happening across Europe, because the patient voice is actually the biggest political constituency in this issue. But we just haven't fully activated yet. And patient power will strengthen, not weaken or threaten the influence of others when it comes to decision making. So my call for today is, let's sit down and work together and, you know, devise a plan, set objectives, and just make it happen.
Fantastic. Thank you, Neil. I'm sure that's a message that's, I hope, gone out widely and will do as we follow up on the summit. Mr. Kelleher, thank you also for joining us today. We're very interested to hear your views as elected official in the European Parliament. We've heard a lot about national policy, and we heard earlier from Veronique Vosper at the Commission. What's the relevance of EU initiatives and discussions here? Thinking of everything we've heard today, what's the relevance there, and how can we use this angle to help advance the heart failure community?
Well, I think they're complementary. I mean, if member states are progressive in the areas of heart disease and heart failure, you know, putting forward strategies, well then, you know, what should happen is that the European Union as a collective should put an umbrella over that in terms of policy development. We saw with COVID, Ed, you know, how it came about very, very quickly, where the European Union was able to come together when member states allowed it to be ambitious. And it certainly was in terms of procurement and vaccines and just a broader rollout of policy around the COVID pandemic. If we look at where we are in terms of heart failure, the challenges on because of demographics, aging populations, the pressure on health services, just looking at it from a cold financial point of view, it makes eminent sense for the European Union to become more active in the whole area of prevention, screening, diagnostics, and that we export best practice across the entire European Union. And as Professor Rosano did say, you know, we have to ensure that it's available to all elements of the population, to all socioeconomic groupings and all age cohorts and all geographical regions. And that's where the European Union, if the member states allow it to take a competency in this particular area of heart disease, cardiovascular disease, I believe, you know, could make a central role in changing how we look at it, how we deal with it. And certainly that would be the area that I would encourage your organization. I will also be advocating it myself. And if we just want to take a template, we could look at the Beating Cancer Plan, which, you know, is now something that's very central to European policy making around cancer treatment, cancer prevention as well. And that feeds into the national competencies as well. So that's a key area where I think we can make progress in the next number of years. And finally, just like we now have the non-communicable diseases initiative, we have the Healthier Together plan in place as well. So that is actually, you know, the start of commitment from the European Union in terms of a policy, but also putting funding in place around research and innovation in the area of cardiovascular diseases, heart failure, and other structural heart diseases.
Thank you, Mr. Keller. We know as well from the wider CVD community that there is a growing ambition, not least in the European Alliance for Cardiovascular Health, to secure such a plan. So I think our call must go out to the heart failure community that I believe they will be successful in doing that based on the ambition that they show and the scale of partnership they delivered. So we must be ready as a heart failure community, I think, to lend our support to that and to understand what the heart failure ask is. What would your message be to national and local advocates or clinical leaders to advance this agenda, or MEPs?
Well, you broke up there a little bit, Edmund, but I think in general, when you look at national or local advocacy groups, I think we have to look at this in terms of we all sharing a common interest and making sure that heart failure and cardiovascular diseases are to the fore. So advocacy groups, clinical groups, industry, academia, for example, all have to work very collectively. And I just think that from that perspective, you know, this particular plan that's been outlined by the European Commission in terms of encouraging research and development. And research and development will be the key in many areas. And again, Professor Rosanna referred to earlier on. We have to get to a stage where we have strong collaboration, not just at member state level, but across the whole of the European Union, collating data, ensuring that we have proper prevention campaigns in place, proper screenings in place, exporting best practices and diagnostics. And then on top of that, we also have to start sharing and looking at the challenges around reimbursement, making sure that medicines, interventions, medical devices are reimbursed in a timely, efficient, centralized manner. We can't have a situation where you can get an implant in one country and not in another. Because if we want to have collaborative research, a collaboration between academia and the industry across Europe, well then what underpins a lot of this is the ability for reimbursement quickly and efficiently. Otherwise, companies and those in the industry will be concerned about getting involved in the development of a new therapeutic or a new medical device. And then on top of that, Europe is a cold place for clinical trials at the moment. And we really have to start looking at that from a policy perspective, how we can change that particular dynamic as to why a lot of people are looking elsewhere other than Europe for clinical trialing. If you don't have clinical trialing, you won't have cutting edge research and innovation. And that's another area I think where academia, clinicians, patient advocacy groups can work collectively along with the European Union at a centralized level to ensure that you have that dynamic in place.
Thank you, Mr. Kelleher. And I think we know from studies on at least the national decision makers that awareness of heart failure as a major cause of admissions is low, as it is in fact of CVD overall. My guess might be that those trends are societal wide, and therefore we might see them in your colleagues. What more could we do to raise awareness of heart failure? So you kindly helped us and other MEPs as well in the production of our action statement last year, which attempts to summarize, just as you said, it's our appeal to maximize the competencies across the European Union institutions on heart failure. I wonder if you had any thoughts on how we could build off this and expand a circle of MEP support. I think as a heart failure community, we're very good at we are never taking no for an answer. We're patient and we wait and we try other means. So do you have any thoughts on where we can go with that?
Yeah, well, already there is successes in the sense that, the non-communicable diseases initiative, heart failure and the cardiovascular diseases are in there now. So it is now something that is actually very much on the radar of the European institutions. From my perspective, obviously we will keep advocating at European level, but I think where we really have to sit down and campaign on is if you look at the demographics of the European population, we're getting older, we're living longer. Heart failure, heart disease, cardiovascular disease in general will become more prevalent. And obviously, with the complexities of treatments and the advances in technology, will become more expensive as well. So we have to try and drive home the concept that if prevention, screening, diagnostics, but in terms of treatment, it is going to get very expensive for the next number of years as we have an aging profile of population. So with that in mind, when you have public pressures across and competing pressures in national budgets, certainly the issue around Europe, supporting member states, getting involved with member states in how they address the key issues around public health will, in my view, concentrate the minds of policymakers both at national level and at European level to ensure they have a strategy around these diseases, which are very complex, very expensive, and if you don't plan for them, could overwhelm public health systems, as has been the case in other areas in previous times where you had no underpinning of a strategy. For example, in cancer care, for example, the technology treatments came on board, but public health systems didn't have the capacity to deal and use the new innovative drugs and therapeutic medicines. So I think, policymakers will have to be encouraged, but ultimately they will see that it is a good idea to get on board at a more centralized European level in terms of heart failure and cardiovascular diseases in general.
Thank you, Mr. Kelleher. I agree completely. We can understand this as a shared challenge across countries, but also, as we've said in this wider this discussion generate excitement about the role of heart failure and the opportunity that we have across many levels, and possibly even reach new stakeholders who would not consider themselves to be traditional health stakeholders in treasuries, ministries of economy, finance, etc., to get them to understand that there's actually a strong offer here from this community. I completely agree. I'm thrilled now just to turn back to some of our other speakers, starting with Gillian once again, from HeartLife Canada. Gillian, we had a question from the audience today. Could patient and carer rights be enshrined in national policy or even law? I wondered if you have any thoughts on that. I know we have seen that in cancer, so why not heart failure?
Well, why not heart failure? Exactly. In Canada, I can give an example of what actually just happened recently, is that our parliament did actually endorse a national strategy for diabetes. And so I think, actually, I think they went one step further. But in any case, yes, you know, but that has taken our diabetes community here in Canada a lot of work over a significant number of years, but also they came together as a team, as a network across Canada of researchers, patients, partners, and everybody came together to do the advocacy work, but to also lay the groundwork for something becoming a national strategy, something becoming an actual policy. And so in that respect, yes, it can. But I also believe that through our rights as Canadians, much of what we've already written there is already enshrined as part of our charter rights. And so what we are simply asking is that you know, we are putting a box around some of the things that we need as patients and patients and family carers in order to move forward, in order to live our best life. And that's, yeah, so I think in some ways it's already is in law, but in other ways we need a strategy to make that happen.
Thank you. And I guess there are sort of soft but equally powerful forms of influence, in, as we heard earlier, in terms of data and the comparison of unwarranted variation, and also explanation of guidelines as well, other ways to empower people from across the whole community. Perhaps I could turn back to Professor Bueno, who joined us just earlier. We had a question from the audience. What was the biggest challenge you faced in setting up the national strategy, and what should colleagues expect based on your experience if they are to follow you?
Well, I don't know whether we had only one challenge. I think Neil mentioned that it is obvious that every country should have a cardiovascular plan, but actually is that obvious that very few haven't. So that's the first challenge. For the last 2 years, everything was COVID. But before and now, I mean, cancer, for several reasons, have catch that much more attention than cardiovascular disease. So I think the first challenge is to have really the push to have cardiovascular health as a priority by the politicians, by decision makers. The second was to move from cardiovascular disease to health. And I think when you need a cardiologist, it's just too late. So we need to really change the society and try to avoid that. I mean, I always say that our biggest success that we wouldn't be needed at all. That will never happen. But actually, that would be the best thing that we could do, that there will be no cardiovascular disease in the population. Again, that's not going to happen. But then when we have this approach, you need to reach a shared vision. And that's not that easy. And particularly to set specific priorities within such a diverse group of people with diverse interests is not easy. So you need to try to get people out of the silos. There's a lot of thinking and working in silos. I mean, cardiovascular professionals or healthcare professionals and non-cardiovascular, hospital and primary care, I mean, healthcare and non-healthcare, because there is a lot that can be done out of the healthcare system and actually needs to be done in the cleaner cities and education in children. So there's a lot of things, but everyone is thinking in their own interest. Everyone has their own agenda. So trying to have a shared view of how to improve this society as a whole, of course, the healthcare system, the continuity of care from primary care to hospital care, specialized care, return to primary care, that's very important. And I think the vision of patients is essential here to help us getting out of our own agendas and views. I think that's very important. It was very helpful in the initiative. I think there's several challenges, but the first one is to get, I mean, we were lucky that actually it was the ministry who called us and say they wanted to do a strategy on cardiovascular diseases, and they accepted to move it to cardiovascular health. But I have to accept that it took 4 years. Actually, it was delayed for I mean, everything was one other priority. So finally we made it, but there's several challenges that we have, and we don't have an European plan as well. So
thank you.
There's many.
The thought will cross my mind, I'm sure many others, that we have the Irish presidency of the European Union in 2025 and the Spanish just before that as well. So possibly quite an exciting lineup. Just a thought, we'll come back on that one. But Winfried, perhaps I could turn to you. Many colleagues watching the summit today may be at a relatively early stage in building an advocacy campaign or a program, and this all may sound good, but they're thinking, well, how do I get there? What do I do next? So I think you're not alone, you know, in that. What challenges have you faced growing an organization really from its first beginnings? What opportunities do you see, and what does a summit mean to you, and how can we and others help you on that journey?
Yeah, you're definitely right. We are early on in our journey. Last year, we changed our name from a regional name to Heart Failure Germany, translated. So we are still ongoing. Our biggest issue is that we face a huge gap in awareness. It's nearly impossible. Only a small percentage of the complete German inhabitants or people have ever heard about heart failure. It's more than 90% in Germany who didn't ever heard about heart failure or have any meaning about the disease. So that's a reason that heart failure is not really recognized at the political level. So that's our biggest job we have to do. I think still we have to do. I'm really grateful to be part of the summit and connected with and learn from others. So I'm working together with the clinical community and with other patients organization is hugely important for a grown advocacy organization like ours. So thank you for your job. It's really great.
Thank you so much, Winfried. We have just time for one last question from the live chat. Giuseppe, I'm going to give this one to you, but anyone else is welcome. So how could we promote and catch up with the classical population not usually included in trials? So, for example, women or people with serious complications. What can we do to plug some of these evidence gaps in major and underserved populations?
You know, I believe that the guidelines address most of these issues on patients or underrepresented in clinical trials. I wouldn't say that women are not represented in clinical trials in heart failure. They're adequately represented, and rather than using what the Americans do of imposing a 50% inclusion criteria, you need to identify differences in pharmacodynamics, so in response to a therapy between men and women, diabetics and non-diabetics, and renal failure and others, to see whether you need to include a specific number of patients and size the clinical trials according for that response in that specific population. But we have evidence from trials that, started in diabetes and then showed the effect of treatments into heart failure. So at the present, what is important is to deliver care of and treatments according to the guidelines. And there are few items, so patients in dialysis, patients with very severe renal impairment, where we need to get more knowledge, especially for the old drugs. For the new drugs, I should say, we have a good understanding how they work in men and women, in patients with preserved and reduced renal function, and all the different subtypes. But at the end, what is important is that once a drug is approved, then we'll need to have a registry and a post-marketing surveillance. And this is something that the European Medicines Agency is doing extremely well in order to identify subgroup of patients that may have adverse events or may not respond. In the future, what we're proposing is to go towards a more personalized approach, but this will take time and will take an effort of all the players in order to look at the specific response of treatments in the different subgroups. But the main message is please implement the guidelines in all patients, and you will find that the ESCHFA guidelines are very specific with a different subset of and subgroup of patients.
Thank you, Professor Fasano. So I know we're at time. I can't resist one final question to Mr. Kelleher. As a former party spokesperson for health, many people would have knocked on your door. How do we as a heart failure community cut through that messaging?
Well, very simply, keep messaging, keeping very direct and forceful. I mean, you will get nothing or you will achieve nothing by being shy. You have a story to tell because it's a story that affects families across the entire European Union. 1.6 or 7 million people will die this year because of heart failure, cardiovascular diseases. 60 million people live with it in the European Union. So it's a story that must be continually told. And I always believe in terms of advocacy, it is about people coming to the fore, be they clinicians, be they patients themselves, and telling their story. That really resonates with the broader public, and things that resonate with the public resonate with politicians. It is these things are critically important. So if you look at it just purely from the cold, harsh reality of trying to kickstart the political administration into responding, that is the best way to do it, is to continue to advocate, continue to tell stories of what is happening in terms of research. Also, and equally, what's not happening is very important to hear as well. We have to advocate for those that are not receiving screenings in time, that are not receiving correct diagnostics, that are not being able to access healthcare. We have to advocate for all the people that are out there that are potentially suffering from heart failure or cardiovascular diseases, or will, if or haven't been identified yet because of poor diagnostics and poor screening. So, we just keep advocating. But I'm very firm of my view that the European Commission, the institutions of the European Union, have now started to look at this particular issue in the way they've been looking at beating cancer. And, all of these things can be complementary in terms of rolling out strategies at European level and getting the member states on board. So if one strategy works in the areas of cancer care, well, why not can't we roll out a European-wide heart failure strategy as well?
Thank you, Mr. Kelleher. So it's a huge pleasure. Thank you all for waiting. We'll close the session one there. I think what we've heard today is that we have not taken no for an answer as a heart failure community. We'll continue to operate in that mindset. We urge action and success. The examples that we've seen have been at many levels, including local and national. We encourage all our colleagues to double their efforts or to begin new ones. We certainly have the evidence. We have a value argument that will cut it. We must be persistent. We face challenges, but we're not alone. You've heard from many networks, ESCHFA, the Global Heart Hub, and ourselves, that that's what we're here to do, to enhance collaboration, reduce barriers to entry, and to share learning. It's been an absolute privilege to chair session one. So much has been done. so much to go. And with that in mind, I do hope that you'll join us for session 2 of the 2022 summit on the 2nd of November, where we'll be looking at innovation in heart failure, shifting diagnosis and care into community settings. A fascinating lineup of speakers for you there, going into some of the detail of how we truly drive healthcare transformation in a way that will matter and mean the most. Thank you very much, and we hope to see you next week.